Datapwa, it's really good to be here with you today. How are you doing?
I am amazing, thank you. How are you?
Awesome. Yeah, I'm good. Looking forward to this conversation. Maybe just tell us a little bit about who you are, what you do, what brings you to this conversation today.
Sure. So my name is Datapwa. I'm a GP. I work in North Kensington, and I'm one of those GPs who's got a bit of a portfolio career. So I have an extended role in population health. So what that means is not only am I able to manage patients on a one-to-one basis in clinic, I also am able to manage the health of a population. So I can look at population, look at the health needs, and have a think about how to improve it collectively rather than on a one-to-one basis. And within that, I'm really interested in health equity. So trying to look at unfair and avoidable differences in people's health and looking at how to tackle those differences.
Great. And you recently published some research, which congratulations, by the way. I know it was a bit of a journey getting there to publish that.
Yeah.
We at FaithAction, we were really excited about this research. Like just a bit of background for listeners. So going back to 2014, which is like crazy long time ago, FaithAction published some research on faith and public health.
That's right.
And I mean, this was before my time at FaithAction, so it's very much ancient history. But that research was like, at the time, nothing had really been done, particularly in the UK, looking, there was no sort of literature review or anything like that, looking at faith and public health and what faith, like ordinary faith communities, the impact they can have on public health. And really ever since then, we've been trying to kind of ask that question, what's happened since? Like since 2014, what's changed? Has there been more research? Has there been more evidence? And for one reason or another, we've never managed to get that research done. But you've come along and you basically like bridged that gap and published some new research, which gets to the heart of like what's been happening since then. So tell us a bit more about that research, what it is, how you came to do it.
Sure. So the paper came out not too long ago, about a couple of weeks ago, and it was looking at how we engage with faith communities in public health interventions to reduce ethnic health inequalities. It was a scoping review of literature across the UK, and I came across to do it for lots of different reasons. Some of them is probably personal. So I remember when I was applying for medical school, I thought I want to improve the health system in Africa. And I've always been someone who's been quite troubled about injustices in different health systems. And I think actually medical school really schooled me because this dream didn't really sort of materialize in medical school. I was too busy trying to pass exams. I was working part-time. But I think over the years, and if you fast forward to COVID, this passion really grew again. And it's because I realized how much health inequalities were in our health system in the UK. I had someone that was close to me in our family who passed away, who was quite young, he was in his 30s, and he didn't get the COVID-19 vaccine and he passed away. And it made me think about, the data that was going around about why people who had a darker skin tone, for example, why they were more likely to pass away during COVID-19. Why was it that people who were living in certain conditions more likely to pass away? Why was it that people who were poorer were more likely to pass away? And those things really troubled me. So I really developed an interest in health equity and trying to adjust those differences. And I think one of them was around ethnicity for me. So when I started to look at the underlying reasons behind the differences between different ethnic groups, it was quite clear that racism was playing quite a big role in that. And I found it interesting because public health actually really put in lots of effort to try to reduce ethnic inequalities. But very often, because those systems, the health system itself, can be reflective of underlying structural racism and injustices, I think sometimes the effectiveness of interventions are not always the most effective very often. So there was something about trying to undo injustices right from the root. And so one of the ways that I started to become interested in this was looking at the work that faith groups were doing during COVID-19. I've always come across this from sort of a global lens. So back in Africa, there's lots of, faith system is quite a complex system. And faith systems there do lots for people in terms of health. So their own health institutions, their own educational institutions. And there's lots of, political, social systems that also come with faith systems as well. But I think there it became very clear that actually faith groups are a force for change. And it was really interesting to see that in the UK becoming more and more of a pattern where we knew that if we wanted to vaccinate certain people who were deemed hard to reach, actually, if you go to the church on a Sunday or you go to the mosque on a Friday or you go to the masjid, you will meet these people and you can actually get them, have a conversation with them and improve uptake with the vaccine. So I think my passion for looking at further into faith really sort of developed during COVID and also because of my past experiences. And I think, yes, I was doing a part-time master's in public health and I had some time to look into it as a dissertation topic. And I think around that time was when I was introduced to you through one of our contacts. And yeah, here we are today discussing the piece of work that's come out from that.
Amazing. So I'm hearing this isn't like some theoretical exercise for you. Like it's personal, like there's a real kind of deep meaning there.
Yeah.
And by the way, when you talk about sort of within Africa, some of the models there with faith, that's Nigeria primarily?
Yes, Nigeria, Uganda, South Africa. So I've done some mission work in Uganda, for example, with actually a pastor from the UK, and we've gone there, we've done some health work. And I think it's across the board where you see that there's lots of different faith groups or faith institutions that are really doing the work that the government actually hasn't been able to do. And that there's always been the tension, I guess, because like I said, faith systems are quite complex and not every part of the faith system always aligns with the work that public health is doing.
Sure.
And so, for example, during COVID, I remember that some misinformation that spread within faith communities. And so you can see that sometimes actually faith communities, because they're so complex, they don't always work with public health. So I was really intrigued about that sort of complexity and how actually we can progress to working a lot better, because there's so much more that can be achieved for groups that are vulnerable, groups that are neglected, and faith groups really have that reach, because that's really part of what they do. I think so. I've grown up with lots of different faith groups, and I've realized that actually one of the overarching themes across all my friends and colleagues that I've met over the years is that there is this thing about, number one, looking after your own body as a vessel of God, but there's also another thing about being good towards humanity as a whole. And I think that very core is actually pretty much the same thing that health teams are also trying to achieve. It's just that sometimes we try to achieve the same thing through slightly different ways, and we can work better.
Yeah. We often talk in Faith Action, there's a lot of like press about the differences between communities and those community tensions. But actually, if you look at the faiths, pretty much every faith will have that duty to other people, that kindness to other people. And if you find that common ground, it can be incredibly powerful. I mean, just as a side question, do you think, like we talked about 2014 and that initial Faith Action review, and then we'll get on to sort of what's come out of your research in a little bit, but just a reflection, like in a UK context, like do you think there's been a shift since 2014 in terms of how government perceives faith? I know in the report you talk about almost COVID-19 being a catalyst.
Yeah, that's right.
For change. Like, do you think there's been this shift in how faith groups are seen by government, public health, all the rest?
That's a really great question. And I'll answer that from a global perspective and then also from a UK perspective. Globally, so the World Health Organization convened their own faith network because they realized how important it was to get the COVID-19 vaccine uptake increased. So globally, public health, there's been lots of work. I think the Lancet also is currently commissioning a piece of work looking at how faith networks can actually continue to progress and support health systems. So it's quite a big agenda worldwide currently. Within the UK, I think over the last couple of years, public health systems have also continued to sort of follow that agenda. So we can see, for example, within health policy. So before I used to hear the term, for example, VCSE very often. And over the years, I've heard more of the term VCFSE with the F there standing for faith.
Very key, isn't it?
Very, very key, because there's that change and people are more and more recognizing faith. Also within London's health system, I had a role with an NHS program called the NHS Legacy Health Equity Partnership. This was a London-wide program. And that program really looked to reducing health inequalities. So taking the lessons from COVID-19 vaccine equity program and trying to spread it across other issues in London. And one of the main streams of work from that program was specifically developing faith networks. So, for example, there was the London Muslim Health Network that was formed. There was the London Jewish Health Partnership that was formed. And just looking at how all these different communities can, all these networks can work with the communities locally and try to improve health. So I think that agenda has really, really progressed. And you can see in the literature. So I think when you did your literature review, there was a few papers that you were able to find previously, but I found 16 sort of really rigorously done pieces of research. And that's quite a lot in the period of 10 years, whereas you guys looked, I think, from 2014 all the way backwards. So there's quite a lot of research that's been done, and the quality of work that's been done is also quite a lot. It's quite good. But I think there's still lots of gaps. And that's probably one of the main things that my work highlights, is that there's been progress, but actually there's still way more that needs to be done.
Yeah. Well, let's dig into it then, because you published this research. You've given us like a sort of headline there in terms of like what came out, but dig into what you did, your sort of methodology, and then maybe we can talk about like some of the key findings that came out of that scoping review.
Sure, I'll try not to be too boring. But if you want to know all the details about the methodology, you can look into the paper. But it's essentially something called a scoping review. And this helps to map out the literature in a specific field over a period of time and helps you identify the gaps in that literature. So what we did was we looked at literature over from 2014 to 2024. And we looked across about 8 sort of academic online databases. We retrieved nearly 3,000 records that we had to sort of sift through. And that was so much, and because we had such limited time during my master's to do this, we didn't sort of look too much into something that we call grey literature. So grey literature is non-commercially published or non-commercial published work. So it's sitting it's reports that's sitting in specific faith groups or specific public health bodies. We weren't able to call through every single public health network to get their data. So this work doesn't represent every single thing that's been done over the last 10 years. It's more so what's been academic and what's been rigorous and what's been published. So we sifted through all the records and we had a inclusion and exclusion criteria, and we included studies that had meaningfully engaged faith communities. What we were trying to find out was actually threefold. So first of all is, how were faith communities engaged in different public health interventions to reduce ethnic health inequalities? So what was the approaches? What were the public health interventions? So that was one part. The other part we were interested in finding out is what were the outcomes that came out from that. And then the third part that we were interested in was what were the barriers and what were the facilitators of actually implementing faith community engagement. So we sifted through all the records. We had 16 studies that we looked through, and they were all quite interesting studies. Some of them were qualitative, so through interviews. Some of them were quantitative, so through surveys. And some of them were quite mixed methods as well.
Great. So yeah, that gives an overview of what you did and the methodology. I want to talk a little bit about what came out from those findings. And I know you talk a lot in the research about trust and relationship being like a key factor that came through. That really jumped out to me when I read it, because it's something that we kind of hear and explore time and time again when we talk about faith communities working in partnership with public health, local authorities, all the rest. Always comes down to that trust and relationship. And it seems to us a bit like it can almost be like a double-edged sword, that like where things are done right, that trust and that relationship is a real facilitator. Like it really speed things up and helps things along. Like you said, those trusted channels, the kind of myth of hard to reach, all of that kind of stuff. But if done wrong, then it kind of flips the other way, and 100%. Suddenly it's a barrier. Talk a little bit about that dynamic that came out in some of the studies that you looked at.
Sure. So that's a great question, actually. And trust is something that has always come up as well in my line of work over the last couple of years in health equity. So trust came as one of the main factors that acted as both a barrier and a facilitator. And one of the things I'd say as sort of just stepping back from that, is actually I've always been interested as to what we mean by trust. I feel like trust is a very complex term, and trust means different things to different people. And also the object of trust can be quite different in different situations. So what I mean is, if we take vaccines, for example, there's actually been some work looking at defining what trust in vaccine actually means. So there's an element of, does this person actually trust the intervention that you're given? Do they trust the vaccine? The other question is, do they trust the person who's given the vaccine? And that person can differ. It can be a GP, it can be a healthcare staff, and the trust can differ based on that person. The next question is, do they trust the organization? So do they trust general practices? If it's a general practice, do they trust the faith institution that's delivering it? That's another question. And the other question is, do they trust the public health system? Do they trust UKHSA? Do they trust pharma? Do they trust researchers? Do they trust the social system? So I think it's a very complex thing to really identify what we really mean. But it's really fascinating because it plays such a big role very often for minoritized groups or groups that have been sort of vulnerable because of that marginalization that they've experienced and the discrimination. They find it really hard to sort of bridge the gap between where they are and systems. And I think because faith communities are actually very often what they trust, faith communities actually hold a very, very high power to get public health to reach those people. So in this piece of work, I think very often the trust wasn't always... It was one of the tricky things actually we're doing the research is that you had to dig in to really pick up what the sort of undertones from what the researchers had said. And very often you could pick up that trust was the factor. So it wasn't always stated as this is trust, but you could pick it up from the way they describe things. So very often you might see it between the ethnic minorities who were participating in public health interventions and the researchers, because the researchers have just come out of nowhere and they're trying to do these things to them. Sometimes it was between the faith groups and also the researchers. Sometimes it was to do with the interventions, the vaccines. They said, why are we talking about vaccines? We don't trust the vaccines. If it was about mental health, for example, they will say, well, actually, mental health is quite a stigmatized thing. So we don't know what you're talking about. And also, we don't trust you. Why are you coming to us at this point in time? So the trust really varied depending on what it was. But actually, what sometimes really helped was there was a few studies where the researchers and the public health team were able to work successfully because the work they did was based off work that was done beforehand. So they built on previous collaborations. And I think it really made me think about how trust is almost like a bank. You can't go and withdraw from it if you haven't actually invested in it. So you need a lot of time and effort to build that trust. And that was something that was another barrier, is that actually very often there might have not been always enough resources in some of the research. So people didn't have that time to build the relationships with the faith communities and the ethnic minority groups. So that research might not have done as well as it could have. So there was a problem with time, sometimes even funding as well. So if things aren't properly funded, how are you going to be able to get people to show up to co-produce, to co-design? How are you going to, reimburse their travel? Because these people have to travel for a very long way to help your research or to help you in your public health intervention. So I think all those things then sort of takes you back to, are they able to trust you as a researcher? And are they able to trust whatever it is that your public health intervention actually is? Yeah.
Because that, I guess, adds another dynamic, doesn't it? It's like there's the public health intervention, which is a whole trust relationship. Then there's the researcher relationship, which, I mean, you're only looking at kind of interventions here that have been studied.
That's right.
The 16 that have been studied. There are thousands more that have been done right across the country with faith organizations, all doing great things. So it's important to recognize that these are the ones where there's been researchers present, they've been asking those questions. I find it really interesting, just that trust dynamic and what that does. You mentioned also about that point about kind of co-production and the role that the faith communities play within the intervention, because even the whole idea of community engagement, to me, it sounds like there's a community that's being engaged. It's almost being kind of the recipient of something.
Right. Yeah.
I wonder if we could talk about like the potential for faith to play more of a role in shaping the intervention, because we do a lot of like work as FaithAction sort of with local authorities and public health, and we're always trying to make that point that if there's an intervention, it has to be owned by the faith community and shaped by the faith community.
Yes.
And like you said, I think some of the most successful things we've seen have been those that are built on previous work. I think particularly of Tower Hamlets Council, within the pandemic, they initially kind of ran this program of just getting infection prevention items out into place of worship. It was a very practical thing. But following the pandemic, they really built on that and then release some more funding to co-design interventions, and you can see that like trust being built. But talk about that whole idea of involvement of faith communities. Was that something that came out in the studies? Is it one of those things where there's more room for that to be done in the future?
Yeah, so involvement is actually quite a big thing. So about 15 of the 16 studies actually involved faith communities in either the design or the delivery of the public health intervention. However, I think what was tricky to say from those studies was the quality of the co-production, because very often they might just mention that, yeah, we had a member of the faith community that helped us produce, but we didn't actually always get the details. When we did, what we sometimes found was there was a lot of power dynamic, sort of power play. So sometimes we might find that because the researchers and I suppose public health systems, they hold the funds and they hold a lot of the expertise. Very often that power play might play out where the faith communities might feel a little bit sidelined. And also when roles haven't been quite clearly defined, people aren't really clear what they're supposed to do and how much they're supposed to say, and will it actually make any difference? So the studies that were qualitative, that really looked into the process of co-production, then definitely highlighted sort of issues around power dynamics. And some of it was also not purely just that power play between the health system and the faith community, but sometimes it was also within the faith system itself. So sometimes you might find that if the faith leader wasn't always on board with what was going on, they might prevent some of the members of the faith community from doing certain pieces of work with the health system as well. So I suppose there's challenges in leadership and also challenges in power play that we highlighted. But it's something that we found that actually when things are co-produced, very often the interventions that come out are a lot more acceptable and they're a lot more feasible for the population. So we had a couple of studies that were, for example, co-designed. And actually, some of them were quite gender sensitive. So some of them were co-designed specifically for women with Muslim women. And it was just interesting to see how the interventions were more accepted because of how the recipients could identify themselves in the pieces of the intervention that came out. So definitely co-production was a big thing. And it was one of the main policy recommendations actually that we made, which was that we think for health systems, faith communities need to be put right from the start of an intervention, be part of the design and not just part of the delivery. And that process needs to really be a system that's made as part of the architecture of what public health is doing. Yeah.
Well, you nicely kind of led on there to sort of where do we go from here? Well, actually, let me first ask the $1 million question.
Oh gosh, okay.
Were these interventions successful? Like, did they have good outcomes?
Okay.
And I guess also, like, what were they measuring? Maybe that's the key question as well.
So good question. So what were they measuring? So a lot of the studies were actually purely done to assess the acceptability of a certain intervention. So that is one key thing to take away, is that we need to do more evaluations on outcomes. So outcomes meaning, what difference does this intervention actually make to somebody's health? Does it mean that they are likely to change their behavior? Does it mean that their diabetes gets better? Things like that. So that there wasn't a lot of, I think maybe about 6 studies actually looked at outcomes in the participants. So that's one thing. very often the outcomes were what we termed as psychosocial among those communities. So it was looking at, well, was there a change in knowledge? So if we give a piece of health education, was there a change in knowledge in the population? Did they maybe intend to stop smoking, or do they intend to exercise more? Was there awareness change? So things very sort of the mental aspect of things. A few studies looked at changes in behavior. So looking at if smoking, for example, changed. But those studies, because there was only one or two of them, there wasn't a sort of a big effect that was found. But actually, I think what really drew my attention was a lot of the qualitative studies looked into the indirect benefit, so the direct benefits of actually being somebody who's a faith community who's engaging with the public health system. So, for example, if a faith leader was involved in some sort of engagement, what was the benefit for them? And that was really interesting because they ended up developing a lot of agency, a lot of skills to communicate with their faith members, and a lot of leadership skills as being part of the engagement process. So being a champion actually really helps yourself as someone from a faith community. So that was one aspect. Another aspect was more so the social benefits. So it really helped to bring a lot of social cohesion. And I think for marginalized groups, community is actually a big building block for their health. So health system only accounts for probably maximum about 20% of your health as a person. But actually, there's lots of other building blocks for your health. And your community around you is a big building block. And when you take communities who have been marginalized, you realize that actually bringing them together is a huge factor in improving their health. So again, this wasn't quite well studied as a quantitative outcome, but qualitatively, you could see that this is something that has impact. So I think we have quite a big step in trying to figure out what are the real behavioral changes that account for that come out of the interventions, what are the social changes that come out of the interventions, but also what are the health equity changes. So if we're saying one community has worse health outcomes than another, well, did that change? Did that difference change because of the intervention? And also, did some of the structural determinants change? So did racism change, for example? Did we change policy? So we need to look for wider health outcomes.
Yeah. So I was going to ask that question. Like, I guess a lot of those outcomes are within the community, right? But presumably, if we're doing this right, then there should be change with the health system itself. And you talked at the top about, racism and some of those structural challenges. Like, surely there's as much need for change there as there is within the behavior of the people of faith,
100%,
right?
Yeah.
So maybe that's like, in terms of where things need to go next, maybe there's more an emphasis on that. There was a quote that I think you were quoting another piece of research, but it just really stood out to me, which is places of worship are trusted, moral and relational spaces where health and well-being is co-produced, which I really like, because you can think a lot about public health interventions, like these discrete things that people come in, they do their vaccine, they do their screening, whatever, and then they leave. But actually this idea that in and of themselves, like faith communities create well-being just by being functioning communities, trusted spaces. And I think there's sometimes not enough recognition of that. It's all like, there's an opportunity for kind of intervention with faith communities rather than what are they doing already? Like, how are they creating health already, which I think is really interesting. Let's talk a little bit about where we go next. Like, maybe the relevance for this for your ordinary pastor or imam or faith community on the ground. Like, what does this mean for the system? What would be the recommendations coming out of this for the system? And then what would be the recommendations for faith communities?
That's a brilliant question. So actually our paper had, because we were specifically looking at how public health was engaging with faith communities, our paper focused its recommendations for the health system, but there's also bits to take up from the paper from faith organizations as well. So I can start with the health system. So we had 7 main recommendations for the health system. So one of them was looking at how can we strengthen the partnerships that we have with faith communities. So trying to make sure that we have more formal networks. So looking at steering groups, faith networks, bringing together community members, bringing together researchers, and ensuring that we have a longer term plan to create partnerships, not just one-off interventions, but long-term partnerships. So that was one of them. The other one was trying to embed it in system architecture. So trying to make sure that it's part of our planning, our commissioning, our governance, and there's actually accountability for it in the health system. So that was one thing. Another thing was looking at co-design, like we've already described, and cultural relevance. So trying to make sure that actually when we're starting an intervention, we are always bringing faith communities right from the start and throughout, even to evaluation of the project as well, and making sure the next one is that things are really well resourced. So not just funding here and there and then no one knows when the funding is going to come back again. Actually having a very clear plan that this will continually be funded throughout the year, and also that you will provide resources like training for the faith communities to actually upskill so that they can, as faith leaders, for example, go and have conversations with their communities. That's really important. The other thing was making sure the health system itself is capable and ready for this. So there's lots of training that needs to be done. I mean, I'm a GP, but I guess because I've worked with faith communities, I'm able to I know how to manage, but some people don't know how to do these things. So it's like, how do you train health system itself to relate with faith communities? That's quite key. The other thing was evaluation. There's something that we say in research, it's something like, in God we trust, everybody else must bring data, right? So decision makers really, really want data. So we really need to focus on how, as a system, we're evaluating this work really well, and we're showing the outcomes that we said, that things that are missing. So it's really clear that this is actually making a big difference. So those are some of the key main health system recommendations we made. Then for faith communities, I think for me it would be actually taking a step back and really thinking from an asset-based approach. It's one of the reasons why I did this research, because I got really just exhausted about hearing all these ethnic health inequalities. You know they're going to be there. But somebody I think it might be Professor Fenton, who always says, when you know better, you must do better. So for me, it's faith communities have so much assets, and I think faith groups need to take a step back and account for those assets and realize how much they have to offer, so that when public health leaders come to have that conversation, they can say, yes, we can do this, yes, we can do that. I mean, the other day in my general practice, I realized that a local mosque near me now has a counseling service for people of faith. And I remember referring a young girl there, and her health outcomes massively improved because it was really adapted to her culture. So recognizing your own assets and really putting yourself out there, that's the other thing. So being proactive, finding out what's happening in your primary care network, in your we're developing a neighborhood health service, making sure you're part of that system, making sure your local council, for example, has signed up to the faith covenant. So those things you have to be quite proactive about. And I suppose the other thing is recognizing that there's lots of benefits for yourself and a team from being involved also in this type of work. It will help upskill yourself. It will help bring social cohesion to your community. So, and also improve the health, because our bodies are a vessel that are supposed to be used. You can't go around preaching the gospel or whatever your religion is without actually being healthy yourself as a person. So actually taking health serious as a community and making sure that we're trying to improve our health is quite key. And I guess the last thing, which same thing for the health system, is evaluate. Always say, this is what you've done, these are your findings, and share, which is what I'm trying to do today. Yeah.
Awesome. And I think there's so much opportunity right at the moment. You mentioned the neighborhood health service and the 10-year health plan. There's so much talk about prevention. And I think that's where these faith communities are so well placed to dock into that. And I mean, I know that every ICB, integrated care board, so the country's divided into these systems that kind of govern the healthcare. There will be some kind of voluntary sector grouping that interacts with that ICB, and many of them are starting to incorporate faith within those groupings. I know, for example, in Northeast London, it's called the VCFSE Collaborative. The faith is very much there, and I'm kind of part of that grouping, kind of really trying to bring that voice of faith into that sort of space. And just when it comes to commissioning, when it comes to decision making, making sure that faith has a seat at the table. So I think I would be saying to faith communities, be asking those questions like, who's interacting with the ICB on behalf of faith? Is there space for faith within those boards, within those networks? Because there's real potential there, but it's also so easy for it to be missed. And your research is really powerful because it means we've got something to wave and say, look, there's evidence here. There's some great stuff that's happened. There's more work that needs to be done. Let's keep on it.
Absolutely, completely agree with that. I think there's so much more that needs to be done, and we need to keep pushing, and that's why we're having this conversation today.
Great. Yeah. Datapwa, it's been really, really great to have this conversation. Really enjoyed it. Lots more to talk about, obviously, but maybe we'll do this again another time.
Yeah, thanks for having me. It's been really a pleasure. I think it's been great knowing you, but finally having this conversation on a podcast. It's been
in person as well.
In person, yeah, it's been amazing. So fantastic, and I hope we get to speak again.
Good stuff.
Yeah,
great.